All right, I'm joined with Russell, myself, Sierra on the end, and Travis in the middle here. I'll just kind of briefly touch on these course objectives. Really what we're going to be doing is talking a little bit about some corneal anatomy and how they correlate to specific ocular conditions. We'll discuss some medical and surgical managements of those conditions. We'll kind of start to talk about towards the end something called neurotrophic keratitis. It's something that I see quite commonly, I would say now, since I'm working with more cornea patients being in Billings here. And then we'll have cases kind of throughout that are going to make it so it's a little more interactive for you guys. Can you guys hear me okay?
Yes.
Yes.
Yes? Okay, perfect. All right. Just starting out here, just as a reminder, I know you guys all know this, but going through the cornea, top layer being the epithelium, moving down into Bowman's layer. I really explain the stroma to my patient as more of like the meat of the cornea, much more of a bulk there, decimes, then into the endothelium. So we'll kind of go through a couple different cases that are kind of highlighting each one of those. Something that's really important in our practice that I'm working with a lot is the surgical interventions. Specifically on the anterior, we're working with SKs or superficial keratectomies, PTK, and pterygium excisions, and we'll have a case coming up on that. Moving into the stroma, PTK, corneal cross-linking is really important too, and something that I really like to talk to a lot of my doctors when I get out in the community. It's really important to be catching those patients sooner rather than later, and then getting them to referring ODs back to whether that be soft contact lenses, glasses, or scleral lenses as well. And then DLK as well. Posterior, there's some conditions that help with decimate stripping, DSEC, and a DMEC. Anterior cornea, starting there. ABMD, super common. If you're seeing it on your patients, please put it in the notes, even if it's very mild. Patients will sometimes come in and I'm explaining it to them, and it's just nice when they hear it multiple times from their doctors and then coming to us as well. Recurrent corneal erosions can be really challenging for certain patients. If you have a patient that's continuing to have recurrent corneal erosions, I really emphasize documenting how often it's happening, because sometimes patients will come in and they'll not really know how long has it been going on, how many episodes there's been, so it's really helpful. Salzmann's nodules, band keratopathy, pterygiums, and then OSSN. All right, guys, so you can get out your phones. This will be kind of our first setup here. It's not on the next slide, so take a really good look here, and then I'll flip over. Basically, it's a what am I? And Sierra, I'll kind of pass this one over to you and just kind of get your thoughts. If this patient came in, sat in your chair, both, let's say that they're planning they want to do cataract surgery this year.
Are you asking me what that is?
Hang on, we'll go back to it. Sorry about that. I'll give this to you guys. Okay, what are your thoughts then?
Looks a bit like a pterygium. And if they're coming in for a cataract evaluation, typically having a conversation with them about, like asking about the stability of it, if it bothers them, if it gets inflamed often. And those are, if I'm stealing your slides, let me know, but those are kind of our like guidelines for suggesting surgical removal, is if they're bothered by it, if it's growing, if it's inflamed a lot. If it's interfering with their corneal topography, then sometimes that's also an indication for removing it before cataract surgery. A little bit of that is dependent on like what lens options they're interested in too.
We have a 1 moment from the back right now. We're going to be pulling up in just a second a little Poll Anywhere slide. So this is where you get to be interactive, and we'll have this throughout the day. So you'll be able to interact with us as we pull the questions and see where everyone's thinking about it. So 1 second as we're pulling that up, and then we'll go from there. So I have a question for you. When you're looking at that spot that you were earlier, you have kind of some what looks like engorged vessels going into that. So as you're evaluating that and you're wondering, is this OSSN, is this a atypical pterygium, what are like some of the key features that you're looking at to say, hey, this is more concerning for OSSN or cancer, or this seems to be maybe just an atypical pterygium with more elevation?
Good question. So I'm kind of asking history of it too. Have they worked in an environment that has a lot of like UV exposure, a lot of wind, debris? I'm also getting a lot of like anterior OCTs. I'm looking at the epithelial layer in OSSN, and we'll touch on it a little bit more later. You're going to get a thickened epithelium, and you also get a sharp demarcation line from your typical epithelial to the irregular tissue there. And sometimes it can be, I'll be honest guys, it can be really challenging to see if it is an atypical pterygium versus OSSN, because I have seen cases that they go hand in hand.
For the short term, can we just pull up the slides and we'll come back? We'll skip the first polling one if that's okay, but can we pull up the slides for this one? And maybe we'll just do a show of hands for this first one if that's okay. So the question, and maybe we'll go back one slide. And we'll show the two slides, actually. We'll do the picture. So the question is, we'll give you the four choices, but is this a viral papilloma, a pterygium, a conjunctival cyst, or a pinguecula? So show of hands, who thinks this is a viral papilloma? Everyone gets to vote. No one wants a viral papilloma. Who thinks this is a pterygium? Any? We got to stick our hands up really high so we can see them. Oh, Dr. Safa, thank you. Committed to that. Okay. Who thinks this is a conjunctival cyst? We got a few votes there. Who thinks this is a pinguecula? And not everyone voted. That's okay. We'll work on that as we go through the day, okay?
We're quiet this morning. We're quiet this morning. Okay. So we'll keep going through this one. Dr. Steiner touched on this a bit, but that was a pterygium for the patient. So pterygiums are a vascular growth of tenons, typically from UV or environmental factors. Signs and symptoms, very vast, very wide. A lot of the time it'll be like a foreign body sensation, redness, watering, and tearing. This isn't that patient, but I just wanted to give you guys an example of when I'm looking at a pentacam, what it might look like. So right eye showing a thickened layer of the cornea there on the right, and it can create a fair amount of astigmatism and irregular astigmatism, and that can really play into my role of what I'm thinking for surgical options after a pterygium removal, if they're thinking of cataract surgery down the road and what implant they might be thinking about. And then on the left side there, you can see just a much more typical pattern just with the rule astigmatism. Different treatments and when to treat. If the patient is uncomfortable, lubricants and steroids can certainly help calm down the pterygium from a patient comfort standpoint, but it's not necessarily going to get rid of it, and that's where an excision comes in. So if a patient is getting a lot of irritation, surface disruption, or the pterygium is moving closer into the center of the visual axis, I would say, talk about having surgical removal there. Can we go to the next slide? Thank you. Surgical removal. Russell, do you want to touch on that just a little bit, what you're kind of doing in surgery?
Yeah, so surgical removal of these, I always tell patients, they're usually nervous about it. It's honestly a pretty easy procedure for them to go through. Typically it's about a 20 to 30 minute procedure. They get monitored anesthesia care, so they don't go all the way to sleep. We do a little topical numbing injection at the beginning of the procedure. So I always tell them, get a little sting right at the beginning. And then after that, for the next 20, 30 minutes, they'll be remarkably comfortable. What I do also share with them, though, is I will not be their best friend for a solid week afterwards. Because again, what happens when we remove the pterygium, we also undermine and remove the underlying tenons tissue, which is where the pathology comes from. And historically we used to just remove it and not put a graft in place, and the recurrence rate, depending on the study you look at, was close to 50%. So now we take a conjunctival autograft, so we actually take some of their own conjunctival tissue, typically from superiorly up underneath their upper eyelid, and we move that into the area where the defect was. and then secure that typically with 2, sometimes 3 or 4 dissolvable stitches plus some tissue glue. And so the big thing, I always tell patients in the aftercare portion of things, it's going to be really uncomfortable. I tell them that it's going to look worse, it's going to be more red and irritated, and it's definitely going to feel worse for at least the first week while those dissolvable stitches are going away. And then over the course of the next few weeks, and we usually have these patients on a 3 to 4 month steroid taper, as long as their eye pressure is tolerating it, will continue to get better and better and better, both in comfort and appearance. But it's not uncommon that they'll have subconjunctival hemorrhages in the area where the graft was put or the area around the graft, and it'll be fairly irritated, particularly the first 3 to 7 days because of the stitches. So relatively easy to go through, relatively not fun to heal up or recover from. So.
I'd say from an expectation point, I also tell them, yeah, we're not your best friend the first 24 hours. And even that first week, I say, hang on, it's going to get better for us. You're not going to like me the first day. You're going to like me maybe a little bit more on week 1. It should be getting better for us. And then by a month, I have a lot of patients that say, it's a little red, kind of comes and goes, but overall, not too bad. Another thing that I also want to emphasize is if a patient is coming in and we're having a pterygium removal, we'll have that done, and I wait a minimum 3 months for the cornea to kind of re-stabilize before we redo and do another evaluation.
Can I add one thing on that? So that'd be like if they're going to be moving on to cataract surgery.
Yes.
And the other thing that I would add that goes into our conversation with these patients is, one of the things, if you look at the topography that you had of that pterygium patient as an example, they may have 2, 3, 4 diopters of astigmatism that is secondary to their pterygium, and that's typically built into their most recent pair of glasses. And so the other kind of visually frustrating experience that they can have is when we remove the pterygium, their astigmatism is way less. If we were looking at their uncorrected distance visual acuity, it would be significantly better because they have less astigmatism, but they're wearing a pair of glasses that was built around 2 or 3 diopters of astigmatism. And I always tell patients, they can always get a temporary pair of glasses, but if we're looking to go to cataract surgery 3 months later, or they're just doing pterygium surgery only, ideally if they can get to a month or even up to 3 months before they do that, because they're going to continue to have corneal healing. And again, there's some patients that we have to get a temporary prescription sooner, but that's just one thing that you might see back in your offices where someone's like, gosh, I'm a truck driver, I'm driving at night, I can't see out of my right eye that just had pterygium surgery 2 or 3 weeks ago. It's fine to get them a pair of glasses sooner to update that prescription because it will definitely shift.
I would also just add, I think that one of the questions we get or that I get in office quite a bit is when should we remove the pterygium? And obviously when the topography looks like that and we're prepping for cataract surgery, it's pretty cut and dry. I kind of think the more challenging patients are, the 35, 45, 55-year-old that we're not considering cataract surgery. Maybe there's been some mild growth, but it's not encroaching into the visual axis. It's not approaching the pupillary axis. And so I kind of share with patients, well, if it bothers you, if it's just aesthetically unappealing to you, we can take it off. If it's, gets more red or a tendency to get more red and that bothers you, we can take it off. Obviously, if it's changing prescription, we can, there's more elevation to it, we can remove it. I think the toughest patients are the ones that come in and that are effectively plano. They've never worn glasses, they've got a pterygium, and they're motivated to remove it. And I kind of tell every patient when we remove a pterygium, even if there's minimal elevation, if there's a potential that your prescription is going to change. Or patients who said, I used to not need glasses and this has started to grow on and I now need glasses, and I tell them, this isn't just going to magically take you back to plano. You're not guaranteed 20/20 out of this. And so educating that vision can change with this. We are removing tissue. Obviously, when that reepithelializes, it gets typically pretty close, but I've seen patients change, with minimal elevated pterygiums, and we see still a half to a diopter of astigmatism change that they previously didn't have and come in kind of upset of, well, I don't see very well. What's going on? I'm trying to share with every patient up front, your prescription can shift from this, and if that means that you hadn't worn glasses and you now need glasses, just kind of making sure that they're aware that it's not a magic wand.
All right. I won't give this one away ahead of time, so I'll let you guys take a really good look at this one. This was a really interesting case that I had actually during my residency, and I'll kind of go into the patient's demographics a little bit here in a moment, but I'll have you guys just kind of take a look at that.
Do we get the demographic information before we have to vote? The history taking is so important.
Well, now I'm going to get it wrong off the top of my head here. About an 80-year-old Caucasian female went into her primary optometrist about, I believe it was 3 weeks prior, which is kind of an acute red eye. It was the first time that she had noticed it. And her primary sent it in to us saying there is a retinal nerve bundle on the front of her eye. Please help. It's about the extent.
Okay. Are we doing a show of hands for?
Well, we'll see it. We'll see if the poll goes through. Does anyone need more time on that?
I think we can do a show of hands off here.
Okay.
Yep.
All right. Show of hands. Who thinks A, OSSN? Come on, guys. Be brave. I know it's early. There we go. All right. B, viral papilloma. Okay. Conjunctival cyst. All right. And pinguecula. All right, little more there, guys. I appreciate that. All right, this was OSSN. I'm going to give you guys a little bit of background of OSSN. It really encompasses a spectrum of epithelial squamous malignancies. It's about a 0.2 to 3.5 per 100,000 in the population. It can involve both the ocular surface, orbital globe, and the orbital cavity. There's a really big range. I've had some that are very mild. I have a couple different cases here, and then some that are much larger. Recently had a case that it was about a 10 by 10 size, took over almost their whole nasal conch. So certainly a vast array of those. So can go anywhere from minimal, moderate, up to severe, and into squamous cell carcinoma as well.
Can I make one comment on that?
Mm-hmm.
The staging of this in terms of mild, moderate, severe, and squamous cell is honestly sort of a historical factor, because the treatment for this used to always be surgical excision. And so you would excise it, you'd send it to the pathology lab. When I was a resident in Utah, we'd get these sent from all over the Mountain West, and we'd sit in the pathology lab and we'd say, okay, how far down in the epithelial layer does it go, or does it break through? And now we'll talk about treatments now, but it's actually very rare that we surgically excise that. So usually in a chart, you'll just see us label it as OSSN, and we won't really necessarily label minimal, moderate, or severe dysplasia or squamous cell, because that's a pathologic diagnosis. So that's maybe kind of one historical factor that you'd see a little less than we would have historically.
So this was the case that I was just, 80, nice, crushed it. So just the mild dry eye, little bit of blurry vision, and irritation left eye. Retinal nerve bundle, front of my eye. And she otherwise didn't really know why she was there. 3 weeks prior, and the OD said this was the first time that she had seen that. So and she had gone to her doctor pretty routinely, so definitely worked with that OD a lot, and I said, nope, first time I've seen it. This is her anterior segment OCT. You can kind of see it, I believe it's off to your guys' left there, kind of that hyper-reflective location. Definitely a thickening of the epithelial layer there, as well as the sharp demarcation line that I was talking about is that kind of bright to the dark. And you're not always going to have a super cut dry anterior OCT like this, but I thought it did a really nice job of showing you guys kind of where the location was for this patient, and then where the quote unquote normal tissue started. Okay. This is the patient after one round of topical treatment. I'm going to be honest, we had a lot of travel issues with this patient. It was really hard for her to get to the location, and it was hard to keep her motivated. She didn't feel like she really noticed much difference in the first cycle, and I told her it's going to take some cycles to really see much of a change, and hang in there, because these patients do go through quite a bit when they're doing these topical drops. We'll touch on it a little bit, but it can be hard. So setting expectations on the front end for quite a bit of blur and redness and irritation. I find patients are more compliant when they know about those things ahead of time. So officially diagnosed with OSSN on the left side. Here are the different treatment options that Russell had kind of touched on. We could excise it and send it off to pathology. That was done, previously, more commonly. The issue with that is you have to get very large margins around the lesion, and you're kind of setting the patient up for a fair amount of scarring, and the scarring itself can cause a lot of irritation to the eye. So now we have drops that show a really nice efficacy of taking care of the lesions. So option to just do straight pharmacy drops. Typically I tell patients it can be around 6. I've had more, I've had less. And sometimes we're really using the topical drops just so we can get it smaller. So then we're removing less tissue. The drops, 5-fluorouracil is a mouthful. I commonly say 5-FU, but I do start out with...
That is rude.
I know. I always start out with fluorouracil and tell them it's a mouthful so no one's offended. It is 1 week on, 4 times a day, 3 weeks off, and then kind of a cycle for about 4 to 6 months. Minimal, no improvement, surgical removal. Something that is really important, and I have had doctors calling into me, I've had patients calling into me, the longer and more cases I've worked with this, the patients are uncomfortable the week they're on it. The most uncomfortable happens to be the 2 to 4 days after. I tell patients they can continue with their lubricant drops, and I do give them some steroid to use up to 4 times a day during that week. I tell them if it's really painful for those first days afterwards, they can, but just also really stressing the importance of not just using a steroid kind of willy-nilly. Boom. 6 rounds, topical treatment. I was able to kind of see her for all of these 6 months. After that, the current resident then at the time kept following with her. I did check in with the current resident just to see how she was doing. And at this point, we're over a year out, and there hasn't been any comeback. So she's doing well.
Can I make a couple comments on this case? So this is like a super great example of where longevity, if you look at that post 1 month treatment, it's almost like, gosh, was there any impact? Maybe a little bit, and patients can get a little bit discouraged. Travis and I yesterday saw a patient that was like your literally 10 millimeter by 8 millimeter lesion that we've been following for a few years, and we've told him multiple times, this is gonna take at least 6 months, probably 12 months of treatment, and he'll get frustrated after a month and stop. It'll shrink down after 2 or 3 months, it'll be better, then it'll stop, and it'll go away. And so I'm not afraid, I think it's okay in this situation to use language that patients are familiar with. So when I talk to patients, and this patient yesterday who's having difficulty with compliance, I remind them, this is a cancer of your eye. This requires chemotherapy medication. If you do not do a complete course of chemotherapy, just like if you did not do a complete course of chemotherapy for your lymphoma or something else, it's not going to be treated. And so we have to be really consistent. And then to your point, I think really emphasizing to these patients, just like with chemotherapy, systemically, people feel terrible kind of while they're on it and for a few days right after treatment. That's super common because you're killing all of those cells. It's going to be the same thing with this treatment, where during that treatment week and for a few days afterwards, your eye's not going to be happy. It's then going to recover. That's why we do the pulse treatment. It's going to recover. We can use the topical steroids to make it easier, but really setting expectations for them that this is going to require extended treatment. And this is a lot more common, I think. We see a lot more of this than I would anticipate or expect. There's a lot of OSSN that's floating around. So if you do see a patient, I will say relative to historical surgical excision, topical therapy is amazing because historically this patient would have had a resection. You need 2 millimeters of clear margins on each side. You do a double freeze thaw all the way around the margin. And so you've effectively taken out 4 to 5 clock hours of their limbal stem cells, and they're at risk for limbal stem cell deficiency and corneal haze secondary to it. So the topical treatment of this is amazing but they just have to be committed to it.
I think I would also just add that OSSN has so many different appearances. Like this one I looked at and I was like, oh, I don't think I've seen one that looks like that. Like just about everyone we see looks a little different. And some very closely mimic a pterygium, some don't look like a pterygium at all, and you can really see these large kind of feeder vessels coming into it. And to what you showed on your slide, the anterior segment OCT kind of evaluating where it sits within the epithelium, or is it thickened epithelium, is kind of the best way to diagnose it. But there's times where we kind of scratch our heads. And again, a lot of it is the history component. If it's recent, if it's come on within the last 3 months, 3 weeks, versus I've had it for 10 years, obviously that's helpful, but they look so different patient to patient. So just as an FYI, if you have a new red eye that kind of looks a little fishy, then send it to Dr. G.
I will see them. I will see them. All right, this is an interesting case that I had recently. She came in for a cataract evaluation, and this was back November, so 9-ish months or so-ish now. But her exam it looked abnormal. There was kind of a elevated gelatinous lesion. I'll show it here on the next page for you guys. What we ended up doing is she actually went through 8 rounds of topical drops. Her whole family was there every single time. They brought a yellow notepad and had tons of questions every single time, which is great. Sometimes in these situations, patients hear the C word, cancer, and they check out. And that's okay. It's a lot to take in. They're coming in for a cataract eval, and now they're starting chemo drops. So it's okay if these patients want to bring loved ones in. You can encourage them to bring loved ones in. I think always another set of ears is great. She did fantastic. She has a small little pterygium remaining, and I just saw her the other week. She's doing great, and we're planning cataract surgery here in a couple months. All right. Sorry for the little bit of glare there. I'm certainly not a photographer by trade here. But on the left there, she definitely had more of a prominent blood vessel moving into the cornea and just kind of a very irregular and raised lesion. I didn't put the photos in here, but she actually, not as commonly, had some kind of haze on the superior part of her cornea as well. That was one of the first cases I have seen with a suspicious lesion superiorly. I'm typically seeing them more nasal or temporal. But good or bad, the thing with the chemo drops is they're going to go over the whole entire eye. So it's not photographed here, but that completely resolved too. So it's kind of nice that it took care of both of those for us. I did put in the anterior segment OCT for you guys here as well. On the left side there, you can see kind of the shadow, the thickened epithelial layer and the shadowing underneath of it. Not quite as cut and dry as the sharp demarcation line there, but you can kind of still see the cutoff from the irregular to regular. And now over on the right side, much less of an elevation. Still going to have a little bit of an atypical appearance because she still has that residual pterygium, but she is doing great. I'm very excited for cataract surgery. Okay, let's move into the stroma. A couple different things there: keratoconus, pellucid marginal, corneal dystrophies and deposits, secondary ectasias coming from LASIK or PRK. And one I see almost every day is just different stromal scars because everyone welds and everyone gets metal in their eye. Okay. Travis, do you want to touch a little bit on keratoconus? You have a patient coming in. What are you looking for in the exam?
I just look at the pentacam.
Fair.
Obviously, reviewing notes, those patients typically come in sent from you all that you've seen some type of progression, whether it's increased astigmatism, whether it's poor BCVA. Every now and then I see something that says something like scissoring on retinoscopy, and I don't know what that is, but it's not good. And so, from a treatment standpoint, obviously the decision is always based on, is this getting worse or not, right? We know keratoconus by definition is progressive, but patients go through phases where it's not progressing, where I kind of tell every patient it's not just a flat line down where your vision is going to continually progress to the potential of a corneal transplant. And that you might go 5 years and it's stable, and then it drops it, progressive for a couple of years. And there's obviously also very differing forms. There's mild forms of keratoconus where patients really never get diagnosed. That we see them in for cataract surgery at 65, and we see some mild, maybe 3 diopters of inferior steepening, a little bit of thinning, and we can kind of tell like this patient's had keratoconus, but it's been so mild that it hasn't really had much of an impact. Tough to diagnose. So outside of that, you can look for obviously more severe cases. We're looking for corneal scarring, the vertical stray, which again typically can be a pretty good indicator that there's some heavy steepening there.
From a treatment option, certainly patients can do in mild cases well with glasses, but the issue with glasses is the astigmatism gets worse. They're looking through just a tiny little spot in their glasses that works for them. So sometimes glasses work because the patient doesn't want anything to do with contacts, and it's perfectly fine. Soft contact lenses can help in cases that the astigmatism can still be corrected in the soft contact lenses. But commonly, more so I would say, is RGPs and scleral lenses. Those are those really hard, big contact lenses. I think they do a fantastic job of helping mask a lot of that irregular astigmatism and kind of irregular corneas that you can get with keratoconus. Corneal cross-linking, that's where we're coming in, and we'll touch on that in a minute here. And typically, as a last resort, we're talking about cornea transplants. We do them. I have patients that come in and they say, give me a transplant. And I say, no, no. We'll start with scleral lenses typically. Usually we're moving to transplants if the scarring is so significant that we're just not getting any improvement with the scleral lenses. Is it progressing? This is a really important slide here. I think it's really applicable to our referring network here. In 2 years is what insurance is looking at. They're looking for progression in myopia over 1 diopter, spherical equivalent change of 0.5, progressive increase in astigmatism over 1, and progressive steepening in keratometry, or Kmax. One thing that I see a little bit of hit and miss on referrals, and that's perfectly fine, not everyone has access to them, but if you have access to the Ks, toss them into the referral. That's really helpful because I can compare it to mine, and sometimes that's enough for insurance purposes as well. So it's just a little plug, little tidbit that's helpful for us.
Alecia, what's the 2 years is how much time for those changes?
Mm-hmm. Yeah. Insurance gets a little picky sometimes. We can, send in appeals, but in general, they're looking at a change over 2 years and fitting that criteria.
I think one of the harder conversations with patients that you've already told them they have keratoconus, they need to come in for cross-linking. Mm-hmm. The Pentacam shows it clear as day, and yet we don't have enough. Either they don't correct well enough to be able to actually see the difference in half diopter of astigmatism. Again, most of these patients come in and you kind of have an idea before you look at the topography, because every refraction you do is kind of like, oh, they look the same, maybe that one, maybe this one, like they don't refract well. And when you don't have a clear cut, we have an increase of diopter of astigmatism in 2 years, or a half diopter of nearsightedness or spherical equivalent. I kind of tell these patients, like, you have keratoconus, this is going to get worse. Almost certainly at some point, not to know to what degree. You definitely benefit from cross-linking, but we have to kind of sit on our hands and wait to check the boxes from an insurance standpoint, and then we just monitor from there. So the more information you all can send when you send a patient in, as opposed to, we saw this patient last month, if you send the previous year or 2 years ago, or even 3 years ago, like, we'll submit, even if it's 3 years old. Like, typically, yes, some insurances are kind of sticklers for 2 years, but we've submitted some for 3 years for prior authorization and have gotten.
Yeah, those are hard conversations. I've had patients that are like, well, you're telling me I have this condition, let's do it now. Okay, usually we try to work with that, but another thing I really emphasize to my patients is corneal cross-linking is super important to do to try to halt progression It is not LASIK. It is not PRK. It is not to fix it. It's not just going to go away. So that's just an expectation I set for patients. And then when we're looking at the actual treatment of cross-linking, day of, they're given a nice relaxant medication because the procedure's a bit long, 60 minutes, then there's a bandage contact lens that's placed on afterwards, really emphasizing the discomfort. I've had phone calls all hours of the night, which is perfectly fine, because they're gonna need some hand holding for this first week. I say the first week is the most uncomfortable, okay? That cornea is settling into position and that tissue is also growing back into place. And if their contact falls out, they are not happy. So sometimes if a contact comes out and we're not able to see them, we might reach out to one of you, see if you guys are in the office to put a contact on there. It just makes it much more comfortable for them. At about a week out is when the contacts are coming off, as long as the epithelial layer has kind of come back. You're going to have some haze that's going to be reducing over about 3 months or so. And then I'm kind of just checking them a week, a month, 3 months, 6 months. I'm just making sure things are kind of stabilizing out. And I have a couple pentacams then afterward just to make sure I don't see any other changes. Russell, do you get this question often of when can I wear my contacts again?
Sarah gets it a lot. She was wanting to answer that one, I think.
Sarah.
I was going to make another comment, but I'll answer it.
Do you get it when patients are cross-linked, when can I wear my contacts again?
I think there's varying answers to that depending on who you ask. I would say, I think it depends on the case. Like if it's somebody that's totally non-functional without their scleral lens, trying to get them back into it as soon as possible once the epithelium is stable and healed is typically what I would tell them, but I think that varies a little bit. There's different preferences on that.
I would agree on that. Usually I'm telling them a month with an old, clean, hopefully, but scleral lens, and I emphasize don't refit into a new scleral lens fit for 3 months.
The comment I was going to make, her question was just that patient that called at all hours of the night. Was that Travis's?
Yes.
Thought so.
I don't know who this patient is, but just so we're aware, patient calls in, they had cross-linking, or they had PRK. They had something where the epithelial's not doing good. It's 9 o'clock at night. My eye's watering. It's throbbing. It's the worst pain I've ever had. What's your, aside from just holding their hand, you can only stay on the phone for so long. What's your plan? I'll give you mine.
I've done both.
Comment.
I've done both. I have met a patient late at night to put a contact back on. I haven't done that for a while. Just being completely honest, it's usually just a lot of discomfort that I'm trying to talk them through. Like, hey, tons and tons of lubricant drops. Try to go to sleep. If that contact falls out, I tell them not to put it back in because I think in general it could fall in the dirty sink, it could fall on the floor. I've had patients put them back in. I've had a patient tell me put it in their mouth and then put it in their eye. So just tell them to leave it out. So it's a lot of lubricant drops. I don't know, how about you?
Well, it depends on how far away from clinic they are, I guess. But I've told patients if it falls out, like, have you worn contacts before? Do you have a solution? If they know how to put it back in, I'll have them throw it back in. I think the tougher patients are when we know the contact is still in place, or they have said, like, I don't think it's fallen out. And so my treatment is I basically tell them to use their combo drop. So they have their Pred, Moxie, Ketorolac, and I'd have them use it one drop every 10 minutes for at least an hour, potentially up to an hour and a half. So they get 6, 7, 8 doses of anti-inflammatory in it, and then basically tell them to get a cold washcloth, rest it over the top. I rarely get a second call. When I tell them, like, if it's not good, call me back. Most patients, once that 30 to 40 minutes kick in with a steroid drop, it'll calm it down pretty quick.
Another important thing that I like to emphasize, do not give these patients proparacaine to take home. I had a patient, I don't know how, truthfully I do not know how he got the proparacaine, and he called me late at night and he said, hey, my eye, it's really irritating. I just had cross-linking yesterday. I've been using this drop. It looks like proparacaine. He definitely didn't say proparacaine, but that's what he spelled for me. And I put it in like 12 times in the last couple hours. Like, it's not helping. So it's important.
And I'll just also say this is a public service announcement for all cornea out there. If you're seeing a red eye that came from the ER or urgent care, there are a lot of Montana ER or urgent cares handing out proparacaine. And I just glued a cornea 2 weeks ago that upon further investigation, the ER had given him a bottle of proparacaine to help with his corneal ulcer along with his antibiotics. And so, again, please ask if they were given numbing drops, and if they were, confiscate them or just remind them that's a great way to melt their cornea and have a lot bigger problem.
Because we don't want to get to this. Russell, can you touch a little bit on what you're talking about?
One of the beautiful parts about penetrating keratoplasty or PKs for keratoconus is we hardly have to do it anymore. And to Alicia's point, this used to be the gold standard of treatment, was we'd watch keratoconus get so bad. Once it was so bad that they couldn't get good vision, we'd do a PK. And to Alicia's point, like we always tell patients, if you get a penetrating keratoplasty, you're going to still need to be almost 95% chance still in an RGP or scleral lens. And so to the point of like these patients who come in and are like, hey, I want to have a transplant now. It's like, no, you get to try a scleral lens. If you don't have a great experience with your scleral lens, try a scleral lens again. If you still don't have a great experience, try a scleral lens again. Because otherwise you're going to have a full thickness transplant and still need a scleral lens and have a transplant if you're 20 or 30 years old that you're going to need 2 or 3 transplants in your life. And so, again, it's still a beautiful procedure, but to Alicia's point, it's primarily reserved for scarring, either secondary to infection or a bad hydrops event in the case of keratoconus, that makes it intolerant of still getting good vision in a scleral lens. But it's actually very, very unusual that we have to do that, which is a huge testament to keratoconus being caught early, cross-linked early, and not progressing to a stage where we need to do PKs anymore.
I would agree. I just want to be conscious of your guys' time, so we'll move forward a little bit here. But a PK, just know that if we are planning to do a PK, they're planning to stick with me for a long time, about 9 months up to a year. And I'm really trying to hold off on doing a scleral lens. There's definitely different takes on that. Some individuals feel more comfortable fitting a scleral lens before all the sutures are out, but typically I'm having all the sutures out and then I'm referring out to the doctors to get a scleral lens. So just setting the expectation to patients that this is not something that's going to be handled in 1 month, like they hear their friends with cataract surgery. This is a very long process, so just being upfront with that. And then these are a little bit of some specialty contact lenses. I do not personally do any of those specialty contact lenses in Billings. We have some very wonderful doctors in the community that do them, and I'm very happy to have them do them. So GPs, hybrids, and sclerals. All right, posterior cornea. Fuchs being the most common that I see, PPMD, there's congenital dystrophies and X-linked endothelial dystrophies as well. Okay. Here we go. Travis, would you treat?
What's the vision?
That's fair. I was looking through these slides last night. I'm like, this is one that it could go, either way. Let's say planning.
So yeah,
Let's plan. So they are corneas 750. They're thick. Vision fluctuates throughout the day. And they're in for cataract surgery. What would be your plan?
So they have reduced vision already, right? We know there's cataract components.
Yep.
If they're 750, then yeah, I would say a DMEC is in order, and I'd have a conversation around kind of combining the DMEC with their cataract surgery. It's a one-time procedure. It's one ride for them. Obviously, it's a longer healing process than our standard cataract patients, versus potentially splitting them up depending on the rest of the health of the eye, doing the DMEC first and holding off on cataract surgery, letting it stabilize for 3 to 6 months, potentially repeating scans to determine if they're interested, potentially in correcting. Maybe they have a high astigmatism, they're interested in a toric lens or something to that effect. But most of these patients I kind of educate, like, most likely to end up in a thin pair of glasses, and so combining them into one procedure is probably their best course.
We'll skip through that poll. But with Fuchs, it's the most common endothelial dystrophy. They're going to complain of like cloudy, foggy vision. Glare and halos can certainly be worse, and it can also be a little tricky because cataracts creates a lot of, foggy vision, halos, glare. So just really important to, during your slit lamp examination, to look really close for the guttae or guttata, corneal edema, and sometimes they'll start to get these decime folds as well. So just taking the time to take a look at that endothelium, it's really important and gives myself, Travis, and Sierra a much better idea going into the cataract evaluation because it can potentially change what we're thinking for surgery. So just having that on the referral is very helpful. Touched a little bit on this, but this would be the process for kind of treatment of, say, like a DMEC. A lot of the time I will start with steroid or sodium chloride drops. I think it's nice when a patient has a month or so of that to say, oh, we didn't just jump right into surgery. Sometimes we do, the patient's already done steroids or lubricants with the referring doctor, but sometimes patients need another month or so to wrap their mind around having surgery on this. So the surgery itself, about 10 to 15 minutes if we're just doing the straight DMEC, tack on typical cataract surgery, 5 to 10 minutes longer if we're doing kind of a combined surgery there. I tell patients your eye is going to be to the sky, so you are going to be reclined, your eye is going to be pointed up. That's for about 48 hours. Yes, they can get up to use the restroom. Yes, they can eat. However, I want that bubble pushing up against the graft, and that's usually for about 4 to 7 days that bubble's in there, but after kind of 48 hours, they can start to lean into being kind of upright a little bit more. Post-op care, just let them know it's going to be really blurry while that bubble's there. Hand motion, we're trying to look through that. So it's going to get better. Sometimes we have to do another bubble, and sometimes that tissue, for unforeseen reasons, just doesn't want to take, and we have to do it again. Doesn't happen very often, but just from an expectation point. And glasses come at about 3 months. I have patients that do it at a month, and it's fine, especially if that's an eye they really need to rely on. I'm good with a month. Otherwise, 3 just from a stable standpoint. All right. We're getting close on time, and I want to be respectful of that for you guys, but to touch on NK, this is something that I've started to see a lot more of. Not that it's more common in the Billings area, but just because I'm working with cornea patients more. It's a damage to the trigeminal nerve that can come from herpetic, ocular surface disease, diabetes, toxic. It's a damage to the corneal sensory innervation, and then it leads to a breakdown of the epithelium. Sometimes there's open defects that aren't healing, and sometimes there's not. It really depends on the staging. But it is shocking to me how many patients have reduced corneal sensation just coming in with mild to moderate SBK. So it's pretty quick, easy test to do, but do not put any anesthetic in beforehand. I'll be honest, even if a tech tells me they did it 20 minutes ago, I'm like, no, please do not put any proparacaine in that eye. I just think it still has the ability to kind of sway the test results. So other things to do, you can do anterior segment OCTs, and your slit lamp exam and anterior photos is important. Management, certainly lubricants, really important. Artificial tears, plugs can do a great number for patients. I think your natural tear is one of the best tears for us. So putting in those plugs, if your office doesn't do them, we do. So happy to help out with that. Serum tears is another great option. It's where a patient would go to a local lab. They'd actually make the drops from their own blood, spin it down, pull out the protein rich, and make specific drops for their eyes. And I've had really nice success with that. BCLs, you can use them. I don't use them too often. I actually use amniotic membranes quite often. I think they do a really nice job of helping heal up that cornea. And then neurotrophic growth factor also can help, but insurance can be a little tricky on that one.
That one you're speaking about oxybate?
Yes.
Okay.
Yes.
Just want to make sure we're clear.
Yep. Last one, we're about out of time here, so just kind of looking at this one, we won't do a poll on it. But this one was staging. This patient came to me open for about 3 months. At first thought it was viral, wasn't really responding to any oral antivirals or topical. We don't know exactly where this one came from. We're suspecting that it had a viral component, but he had been open for quite some time. Lots of lubricants, some antibiotics, 2 amniotic membranes later, 4 months down, and he is closed. So I touched on what we did there for you guys. Any questions?
And maybe just, because sometimes we get asked about like how urgent it is as it relates to the staging. So when you're thinking about the staging 1, 2, and 3, just as a reminder, stage 1 would be like SPK but no official epithelial breakdown. Stage 2, epithelial breakdown but no ulceration or stromal involvement in stage 3. So if it's getting to stage 3 with stromal melting or involvement, that is a really big deal and needs to be hammered. The hope would be catching it at a stage 1 level, preventing it to go to stage 2, but definitely preventing stage 2 from going to stage 3 where you have ulceration and then oftentimes long-term scarring that exists afterwards.
We did have one question from the audience requesting some conversation around Athens protocol, so corneal cross-linking with PRK. Kind of what's your experience, what do you feel is potential for these patients' outcomes? When do you say yes, when do you say no?
Yeah, I'll take a stab at that. So Athens protocol, which means combined corneal cross-linking with topo-guided PRK. And traditional Athens protocol means you're doing it simultaneously. So same day, corneal cross-linking, or a day apart cross-linking and topo-guided PRK. And I think, if a patient has, in general, if you look at the data, there's kind of criteria around maximum steepness, maximum thickness that the cornea needs to have. But in general, you can see about a 1 to 2 line gain in both uncorrected and corrected distance visual acuity. But it also is quite variable. So the consistency that you see in terms of response when we're counseling patients is, you might get a little bit of improvement, you might get a moderate amount of improvement. This is definitely not going to get you glasses or contact lens free, but where it's a nice sweet spot is particularly if you have somebody who's scleral lens intolerant and we're maybe trying to get them into a soft toric or otherwise and get better quality vision, it can be nice. In all reality, because the topo-guided PRK part is not covered by insurance, just to be quite frankly, probably 98% of our keratoconic patients are just doing corneal cross-linking, period. And just starting with that, you can go back and do topo-guided PRK like a year after corneal cross-linking. So I always tell patients you could still do that down the road if you wanted to consider it. We've done a few cases, had some nice responses, but again, it's not a super common thing. Most patients just elect to do corneal cross-linking only because it's covered by insurance, and they're typically already in a scleral lens or doing well from a vision perspective. But it's definitely a unique treatment option. It is just not a magic bullet that's going to fix everything for it.
All right, well, that concludes cornea. Thank you, guys.